I'm pleased to welcome you here today to the Rock Ethics Institute Health as a Human Right lecture series. As you know, this is a lecture series that has been occurring over the course of this academic year in an effort to get people here at Penn State and beyond, including the College of Medicine, to be thinking about the types of issues involved in the question of health as a human right. Let me begin by inviting you to return on March 20th when Ophelia Dahl, the Executive Director for Partners in Health, will be here to talk about that organization, Partners in Health, from Haiti through Rwanda. In the process of listening to these lectures, we invite you to think about just what it means to talk about health as a human right. Many individuals talk about the ethical implications of the right to health, questioning, for example, whether or not it's sufficient to include equal access to health care, although stressing the importance of access to health care, but also suggesting that attention to public health issues, the impact of poverty on health, as well as the various causes of health disparities, both nationally and internationally, are important topics for us to be thinking about as citizens of a nation that prides itself on being attentive to ethical concerns. So I invite you to think with us today about some of these topics, and once again beg your indulgence as I thank the various sponsors and co-sponsors of this lecture series, which is made possible in part by support from Richard and Ronnie Lippin, the Arthur W. Page Center for Integrity in Public Communication, the Center for Healthcare and Policy Research, the Center for Human Development and Family Research in Diverse Contexts, Children, Youth and Families Consortia, the Department of Biobehavioral Health, the Department of Health Policy and Administration, the Department of Sociology, the Gerontology Center, the Penn State College of Medicine's Department of Humanities, the Penn State Pre-Med Program, the School of Nursing, and the University Libraries. Rock Ethics Institute events are also made possible with the support of a generous gift by Doug and Julie Rock. As you can see from the very long list of co-sponsors, there are many units and individuals across campus that see this topic as a very important issue for us to be dealing with. And I'd like to invite Ken Weiss, who is our Evan Pugh Professor of Anthropology and Genetics, to introduce our speaker for the day.
Thanks very much. I'll try not to be too long about this. I had not met our speaker before today, but I think you're going to have a good time. Sofia Gruskin is the director of the Program on International Health and Human Rights at the François-Xavier Bagnoud Center for Health and Human Rights, and she's Associate Professor of Health and Human Rights in the Department of Population and International Health, both of these at the Harvard University School of Public Health. Her work emphasizes policy and practical implications of linking health to human rights, with particular attention to women, children, gender issues, and vulnerable populations, and specifically in the context of HIV and AIDS. Much of Professor Gruskin's work is geared towards ensuring that human rights and gender concerns are incorporated into the provision of care for people who live with AIDS, particularly those who live in areas without a lot of resources. She's developed and conducted courses and training in health and human rights for academic institutions, agencies, and organizations of other kinds around the world. I'll say a comment about this in a minute. She's been particularly engaged in shaping the strategies of international organizations to fully reflect the integration of human rights into their work, as well as helping to conceptualize the ways in which human rights can impact the research agendas of academics and policymakers who are concerned with public health. She has extensive experience in research, training, and advocacy with non-governmental, governmental, and intergovernmental organizations alike who work in the fields of health and human rights. And I just want to say, for those of you who are students, this is an example of someone who actually takes working in a university out beyond a university and gets things really done. And hopefully it can be a kind of inspiration for those of you who are planning to go into these areas to get out there and make a difference. And I'm sure you'll enjoy her talk. She's a live wire, as we found out just by meeting her earlier today. Her title is Health and Human Rights, No Longer a Question, Moving from Concepts to Action.
Thanks. Can I say I'm not the only live wire that was at lunch today? Okay. I want to start actually by thanking the Rock Ethics Institute for inviting me. It's an honor to be here, and I really do hope that in some small way that I can contribute to the vision that you had in inviting me. So we'll see, I guess, in the question and answer in terms of the discussions that we have, if that can work. Having said that, I guess I need to start by saying I'm having a bit of a crisis of identity, and I want to start by naming my crisis of identity, which is that my training initially is as a human rights lawyer. And when I see that this series is called Health as a Human Right, part of me feels the need to make this a legal talk and to talk about health as a human right in the very kind of legal sense. Okay, but in truth, these days I'm much more on the side of the world that's about public health. And I sit in a school of public health where my work is really about how to take human rights and move them into public health work in terms of programming, in terms of research, in terms of advocacy, and a range of different kinds of ways. And my work is not only on the right to health, but on rights in general as they impact on health. So I kind of am going from sort of both sides here. So I guess, excuse me if I kind of schizophrenically go between the two, but understand why that's happening in the context of the discussion. And hopefully, if there are things that are not clear in the question and answer period, you can call me on those things and we can have that discussion to make sure that I'm clear as I kind of go back and forth. And I'll try to clarify when I'm going from being the public health person to being the law person, but that may be clear enough as we're talking. Okay, so let me actually begin with kind of my fundamental premise here, which is that health is largely influenced by the environments in which people live, and that the extent to which governments respect, protect, and fulfill all human rights, economic, social, cultural, civil, and political, is relevant not only to who falls ill, but actually to what is done about it. Now, from a public health perspective, explicit attention to human rights shows us, first of all, who is disadvantaged and who is not. And in doing so, what it does is it helps clarify whether a given disparity is a difference or is actually an injustice. So, for example, more privileged groups who claim that high rates of maternal mortality in some disenfranchised ethnic minority merely reflect different cultures or different lifestyles, or the idea that the poor have poorer health, because they have health damaging behaviors because that's just what they're about. Now, not only is that incredibly annoying, but in addition, what it does is implicitly, it actually provides a rationale for not committing public resources to address the conditions in disadvantaged communities. Now, recognizing these differences as injustices actually provides a framework for action, and human rights can give that kind of framework. And it actually gives you the power to be able to systematically address not only health care, but the underlying determinants of health, and actually provides a compelling compelling argument for government responsibility, not only to provide health services, but actually to alter the conditions that create, that exacerbate, and actually that perpetuate poverty, deprivation, marginalization, and discrimination more broadly. Now, that's all well and good, but actually, what do I mean by that in concrete terms? So let me just begin by saying something about the ways to think about the relationships between health and human rights in a way that hopefully can help clarify what I'm trying to get at. There really are three ways to think about the relationship between health and rights and how they interact. The first is that you can look at the impact of health policies and programs on human rights, and whether in the ways in which they're designed, the ways in which they're implemented, as well as the ways in which they're evaluated. Do they burden rights or do they promote rights? And if they promote rights, are they actually better? Are they actually more effective as health policies and programs? For example, take an HIV testing policy. Look at who's being impacted and who's not. Who's being considered, and in what ways are these populations being considered? Is it harmful or is it helpful in terms of how it's being done? And therefore, does it burden rights or does it promote rights? Now, the second way is you can look at the impact that the neglect or the violations of rights can actually have on health. And here I'm talking about both in peacetime, but also in war and in times of conflict. And I don't mean just for individuals, but also in terms of populations. Think about the impact of torture, and the impact of torture not just in the immediate, but over the long term, intergenerationally, the way that that can have an impact on not only individuals, but their families and their communities. Or think about the impact of the genocide in Rwanda, not only when it happened, but over the long term. The impact now as people are living together in communities and trying to operate. Or what about the impact on the health of young girls, of denying them the right to education? Or something I think in this country that's particularly relevant given the current administration, preventing adolescents from receiving accurate scientific information in terms of how to prevent HIV transmission. So all of these are ways in which we can think about the neglect or the violations of rights that they can have on health. Now, the third way, which is really the way that's the most kind of useful in terms of actually being able to work with it, is to think about the underlying social conditions that all of us know impact on health status, and on our vulnerability to preventable disease. And to think about how human rights and a human rights framework can actually offer kind of an approach for trying to improve these conditions. And really, in the context of this talk, I'm going to be kind of jumping between these three. So these are really kind of the kind of the schema for kind of thinking about how these pieces come together. Now, in order just to get us started, I guess I want to begin by noting the good news, which is that in many ways in the world of public health, in the attention has changed from what it used to be, which was why should we deal with human rights, to now it's really about how should we deal with human rights. Now, the fact that human rights are useful to public health work in many ways shouldn't actually be surprising. In many ways, given the progressive tradition of public health in so much of the world, what's actually a bit more surprising to me at least is how long it is that it's taken for that to actually be the way that people are thinking of things. Now, I have to admit, which is kind of obvious when you heard my introduction, I'm someone who, without embarrassment, calls herself a health and human rights person. Right? But having said that, I also want to say that over the last 15 years, what we've really come to understand is that stigma, discrimination, and human rights have to be understood and have to be addressed in the context of the ways in which programs are delivered, or no matter how great the services are, no matter how much money is put towards actually making services available, behaviors are not going to change sufficiently to actually improve health outcomes. And even if the services are there, they're going to be underutilized. Now, having said that, I also need to state the flip side, which is that while at a rhetorical level, the need to pay attention to rights is now relatively undisputed in a rhetorical sort of way. In a number of places around the world, what's being called unnecessary attention to human rights is actually being blamed for the inadequate success of public health strategies. That's true in HIV and AIDS. It's true in child survival. It's true in reproductive and sexual health. It's true in a range of different areas that relate to health and well-being. And from my perspective, I think this call to what's being called to get back to more traditional public health strategies is rather vague. I think it's pretty unfocused, but I think it does highlight the need to better document and to better provide the evidence of the effectiveness of rights-based approaches for health. Now, even those of us who actually think that the ultimate success of HIV or of health strategies kind of generally has been hampered by the failure of governments to actually fully integrate rights into their efforts, rather than because they paid too much attention to human rights, it's clear to me that we need better evidence of the positive difference that attention to human rights can make. And that's why I think that it's critical that we take much more care in terms of ensuring that attention to rights is better integrated into the measures that are used to actually determine program effectiveness. And that's something that I'm going to come back to towards the end of the talk, but I just wanted to flag it out now. Now, in the rest of the allotted time here, what I want to do is I want to focus on some concepts, on some concrete examples, but also raise some questions in terms of what it is that we can and what it is that we should do in terms of thinking about how human rights belong in public health. And when I say that, I'm talking about public health both in terms of the ways in which we address what are called the underlying determinants of health, but also the ways in which human rights are relevant to the ways in which health policies and programs and services themselves are actually being delivered. Now, in order to be able to have this conversation, and as basic as it sounds, I actually want to be clear about what it is I mean when I say human rights. It seems to me that no matter what our particular area of focus, that we need to understand the differences in how we're using terminology. Because in fact, the words human rights are used in a variety of different ways. And frankly, from my own perspective here, I think it's either the blessing or it's the curse of the language of human rights. But it's language that everybody feels that they can own and that they can use in whatever way they like, in a way that you don't see with epidemiology, that you don't see with clinical medicine, that you don't see with biostatistics and with other disciplines that are concerned with health and well-being. And I think we need to be clear about that and understand the differences. So I want to be clear about the different ways in which I understand human rights, and I hope you'll bear with me as I try to do some very basic definition stuff. Now here comes kind of the lawyer stuff, okay, just a little bit of that. Now, in all cases, human rights are concerned with the enhancement of health and well-being. And they're based on a sense of fairness and dignity. And within modern history, it was really the world's reactions to the atrocities of the Second World War that called for the need not just for human rights, but actually for human rights law. Now, traditionally, human rights law in the first instance is meant to guide the actions of governments. And the human rights norms that exist in the form of international human rights treaties. And these impose legal obligations on the governments that ratify them. And the thing to remember about this is that these documents have tended to be drafted by government representatives. And so they form the body of international law, but the governments agreed with one another or what it is they consider as governments to be their responsibilities in terms of what they think they can do to us as individuals, what they cannot do to us as individuals, and what they should do for us as individuals. Now, the principle of non-discrimination is overarching to everything. And these human rights documents include civil and political rights, like the right to vote, but they also include economic, social, and cultural rights, like the right to health. And what ratifying these documents does is it gives governments an international legal obligation to ensure that their laws, that their policies, and that their practices are actually in compliance with the rights that are in the treaties, which means that human rights law actually can be seen to set out the obligations of the state or people who work on behalf of the state, including people who work in departments of health or in ministries of health in terms of what it is that they should be doing in terms of their actions. And I have to say that one of the things that I found to be incredibly useful about this is that on a practical basis, to refer back to these documents allows a framework where you can build consensus when you're meeting, whether as an academic meeting with government folks or governments meeting together or bringing together people from different governments or from a range of different kinds of institutions. If you're trying to determine a framework, for example, to look at how to determine inequalities in health, the human rights documents offer a general frame that everybody can know and understand. And at this point in time, every country in the world, including this one, is party to at least one human rights treaty that includes human rights that are relevant to health. Now, even if the details are controversial, or is the case with the current government that they consider human rights really to be antithetical to the ways in which they conceptualize health, the fact is, at this stage of the game, every government is in fact legally responsible and accountable for what it is that they do in the context of health. Now, if people want to in the discussion period, I'm happy for us to talk about the U.S. government in particular and which ones of these treaties have been ratified, but I'm not going to go into it now, but I'm happy to get into that conversation if people want to. Now, having said that about human rights law, Nonetheless, the ways in which people use the language of human rights is very different. And I'd like to briefly describe 3 ways. The ways in which people use human rights for advocacy, the ways in which people use human rights in terms of legal accountability, and the ways in which people use human rights in terms of implementation of what's called often a rights-based approach. Now, in terms of advocacy, the language of rights is really useful to draw attention to an issue. The language of rights can help to mobilize public opinion, to be able to really kind of push for change, whether it's change in the actions of governments or of institutions like multinational corporations, pharmaceutical companies. I mean, the range of kind of institutions that exist. So, for example, the push right now for ensuring wider access to HIV treatment for people who are in poorer countries. So therefore, a lot of people are naming a right to HIV treatment, even if in a legal sense, the right does not yet exist. Now, what the legal standards are is not actually what's initially most relevant. It's about getting attention to an issue. And the language of rights is incredibly useful for trying to mobilize public opinion and getting people focused and to recognize this is something they need to pay attention to. It's not technically correct in a legal sense, but it doesn't matter because it's what's about getting the attention. And in many times when people think about rights in the context of health, that's the approach that people are thinking about. And I just want to say, I'm not in any way saying this is a negative. This is just to understand exactly where it is and how it is that rights are used in that sense. Now, just to contrast that in terms of how rights are used as a set of legal norms. And here it's about the international human rights treaty obligations. It's about, at a national level, the ways in which governments put into place laws, policies, practices to be in compliance with the obligations that they have. And it's about how non-governmental organizations and monitoring mechanisms that exist use the legal norms to see if any violations are taking place and to name them. So the thing to say here is that if you're thinking about using human rights in a legal way, it means, for example, that you're working on recognizing and if appropriate, actually exposing government obligations and the violations that are taking place. So, for example, investigating the level of government action or the government inaction that contributes to the fact that a particular health issue exists, or how a government deals or doesn't deal with a health issue once it's been identified, as well as providing some sort of recommendations and approaches as to actually what can be done about it. Now, the focus is primarily on transparency, on accountability, on functioning norms and functioning systems. And at a national level, it means using the courts. It means using national level remedies to enforce rights. And at an international level, it means using the fact that when governments report on how they're in compliance with the treaties that they've ratified, the way in which the reporting mechanisms work, which is something I'm going to talk about in a minute. And it's about how it is at an international level that this can be used to not only bring public shame onto the government for what it's doing or not doing, but also to actually change government policy and government practice. Now, the third way, really what's called often a rights-based approach, is how governments and non-governmental organizations use these standards in terms of trying to put into place policies and programs. And what I want to say, first of all, is that there is a tremendous amount of documented as well as undocumented evidence that shows that rights-based approaches to health are actually effective. But this knowledge is unfortunately actually not widely accessible, and what exists is really not that understandable, whether to policymakers, to program managers, or really to the general public. And one reason for this is that I think that there's generally a lack of consensus as to what actually constitutes a rights-based approach to health. And organizations that claim to implement a rights-based approach are often doing very different things under that one particular heading. If I can say, in fact, I think in many ways how rights-based approaches are implemented actually has more to do with the missions and the objectives of a particular organization at times than actually a common definition of what it means. Now, there's no one common approach, but there is something called a common understanding. And the United Nations put together what they call a common understanding for what a rights-based approach means. And while if you look at it, the implications for implementation are actually not so clear, it does offer a common understanding for thinking through these issues. Now, we conducted a review of public health programs that the UN system and its partners had in place to try to define what was meant by a rights-based approach and what was actually being done to kind of implement this. And we came up with actually 3 points that I think are relevant for being able to say what a rights-based approach to health means. The first thing, this may seem kind of obvious, is they make explicit reference to human rights. Now, the reason I say that is it's not just that they go back and look after something has happened and say, oh, that was human rights, but they explicitly make reference to the fact of human rights in the ways in which they set it up. Now, the second part, which I think is kind of key, is they focus on emphasizing building capacity. It's not about a way to name violations of rights after they occur, but actually about preventing violations of rights in the first place. And the third is that they're based on several core principles and trying to implement those core principles, which I'll talk about in a second. Mostly non-discrimination and participation. And finally, these rights-based approaches have elements of both what I'll call substance, which means that they're not inventing rights, not like the right to treatment. They're actually dealing with existing rights and also not trying to add content to them. And they're actually looking at processes and how it is that actually rights can be better integrated in terms of the ways in which programs are being done. Now, if I were to say from what we've looked at, and you'll hear this in kind of the rest of what I'm going to say, the key components of a rights-based approach to health are really these. And I just want to explain them in just very briefly. In terms of participation, it's really about how programs ensure the participation of affected communities in the ways in which they're designed. In terms of non-discrimination, it's really about how the program is targeted, who it targets, and in what ways it targets different populations. And attention to the legal and policy context is really about trying to see the intervention not just on its own terms, but in terms of the larger environment in which it takes place. And in terms of transparency, that's about having transparency about the ways in which priorities are being set, about the ways in which decisions are being made, so that people know how it is that these decisions were made and have access to that information. And finally, that there's some level of accountability for whatever is done, not just in terms of how the decision was made, but in terms of its actual outcome, so that there's accountability on the part of the government for what it's done. Okay. Now, here's again where the lawyer in me comes out, okay? Since this talk is on the right to health, I want to just say something specifically about the right to health. Conceptually, the right to health, as it's stated in the Covenant on Economic, Social, and Cultural Rights, is the principal framework for understanding governmental obligations in terms of health. Now, if you look at the way that this language is written, you'll see that it emphasizes both the underlying preconditions that are necessary for health, but it also emphasizes what's necessary to provide good medical care. Now, let me just say that kind of at a practical level, I think I said earlier that when a government ratifies a human rights treaty, they have an obligation to report. And they have an obligation to report essentially practically every 5 years about how they are or they're not in compliance with the rights that are contained inside the treaty. And the way it works is that these treaty monitoring bodies meet twice a year and they review government reports. The government comes to the meeting and presents its report and shows how they're in compliance or how they're not in compliance in terms of what it is that they've done. And then there's a dialogue that takes place with the treaty body about what they've done or not. And at the end of the session, the treaty body prepares what are called concluding comments and observations. And those concluding comments and observations are where the treaty body says, in this way, government, you were great. This was perfect. But in other ways, these are all the things that you still need to work on, and these are still all of the substantive parts of what you need to be dealing with in order to make sure that you're in compliance. Now, for each of the treaties, what happens is that there are guidelines for reporting where a government is told how to present the information. Now, in terms of health, again, the treaty bodies say that governments have to report of both the underlying conditions that are necessary for health, as well as to how they're delivering services. Now, in order to assist the treaty body, so that the treaty body members don't just have the government information, other folks prepare information so the treaty bodies have other information so that there's a more genuine dialogue that can go on. Now, health-oriented institutions like the World Health Organization, like UNICEF, provide the treaty bodies with information as to what they know about what that particular government is doing in terms of health and the delivery of health, so that the treaty body can look at that information. And at the same time, non-governmental organizations like Amnesty International, like Physicians for Human Rights, a range of other more health-related human rights organizations will also give the treaty body information. That's often called a shadow report, so that the treaty body has all of that information that they can use in terms of actually analyzing the degree to which the government is in compliance. Now, that's how it's actually supposed to work. But even so, if you look at this right, you can see it's still not exactly clear, like, what are the components of what needs to be looked at? Exactly what are the pieces that would show whether or not a government is compliant? And that's where general comments come in. General comments are what the treaty body puts into place to be able to say, this is our formal understanding of the content of the right. Beyond what's on paper, this is how we understand what's here. And this is really meant to serve as a guide to governments to understand how to play with and understand the content of the right, but also to be able to think about how they allocate resources, and also to be able to think about the ways in which they actually take steps to be able to show what they're doing. Now, in terms of the right to health, let me just say, if you look at the right to health and the way that it's written, and you can also see kind of historically the timing of when it was written, because there's language in there that is sort of not so much used currently these days. But the fact is that if you look at the way that it's written, for example, the concept of primary health care isn't there, right? The idea of health beyond just in some very kind of general ways really isn't there. And in large part, that's because the concept of primary health care wasn't in place when this treaty was drafted and when governments started to ratify it. So even if the guidelines for reporting mentioned primary health care as an important concept, the relationship between this approach and the government obligations in terms of the treaty have not been sufficiently spelled out. So what the general comment does is it tries to make that more concrete, because otherwise, unless you had something specific in there, it would be hard to judge the country as not being compliant. Let me just to give an example. If a country said, okay, we have 10 functioning hospitals in the capital city. If you look at this, there's nothing that says that that's not being compliant, right? But if you have a general comment that explains in much more detail that in fact you need a primary healthcare approach that pays attention to the health of the entire population, that in fact you need to make sure that services are equitably distributed amongst different populations and all of that, it's much clearer what you're actually trying to get to in terms of the obligation. All right, so in 2001, the committee that monitors this covenant issued what was called a general comment on the right to health. And in that general comment, what they did, which is easily downloadable from the web, and I highly encourage everyone to pick it up because it's really quite interesting in terms of its content and its components. But what it does is it says a few things. First of all, it really sets out in very concrete terms the boundaries of government responsibility for health. And it emphasizes the underlying determinants of health so that a government's responsibility for health is not only health services, but clean water, education, the range of things that are necessary for people to be healthy in a society. And in terms of services, the key thing that it does is it focuses on the availability, the accessibility, the acceptability, and the quality of the service. And we often call that the AAAQ: availability, accessibility, acceptability, and quality. And if you think about those are really key to being able to think about services from a rights perspective as to whether they actually are available to the population that needs them in the ways in which they need them to be. Okay? And again, we can come back to that in the discussion if people want to. Now, in all countries, I mean, if you think about all of that, there's no sense that every government is going to be able to fulfill all rights immediately and completely. You think about the right to health. There's no country in the world, including this one, that has the resources to be able to actually do it all at once and do it perfectly. And that's where this concept of progressive realization comes in. The human rights machinery recognizes that it's absolutely impossible for any government to fulfill all rights immediately and to fulfill all rights completely. Take the right to health. I mean, it's going to require more than just a commitment, and it's going to require more than just passing a law. I mean, it's going to require, in a really practical way, financial resources, trained personnel, facilities, drugs, supplies, I mean, and even more than anything else, a sustainable infrastructure. I mean, there's a range of things that need to be in place in order to make those things work. And therefore, realization of rights is generally understood to be a matter of progressive realization. It means that a government has to show that they're making steady progress towards a goal. And that means that they have to set benchmarks and they have to set targets to which they're going to be held accountable as it is that they're functioning and as it is that they're operating. Now, this principle of progressive realization is critically important in terms of thinking about what it means to achieve human rights. And it's obviously really important for resource-poor countries, because it's really important to be able to show for resource-poor countries that they are responsible for striving towards to the maximum extent in terms of what they can do about human rights. But the thing that's talked about a lot less is it's also true for resource-rich countries. So it's also true in terms of resource-rich countries, not only in terms of what they do for their own populations, but what they do in terms of technical assistance and cooperation. So in terms of development assistance, so that they're showing that they're always doing better. Now, this point is increasingly relevant when we think about, for example, trying to make HIV/AIDS treatment available to people living with HIV in developing countries. Who has responsibility for that? I mean, who's responsible? And who should be paying for that? And who is it that needs to be engaged in that? There's really a recognized difference here between government incapacity, which is something that the concept of progressive realization is meant to take care of, and government unwillingness, which is really not considered acceptable. And this difference between incapacity and unwillingness is really key to being able to think about how rights and right to health particularly are being realized. Now, for myself, I mean, the reason I focus on kind of this legal piece of it, for myself and the work that I do now, it's really important that I'm using rights in the most legally supported ways possible. It doesn't mean that I'm not pushing to try to expand those definitions. It doesn't mean that I'm not trying to move away from where the concepts are and to take them further. Far from it. But it does mean being sure about what those legal frameworks are and then realizing when you're stepping over that and when it is that you're moving, which is why I wanted to ground those concepts in terms of what it is that we're talking about. That being said, I'm not going to probably do anything else lawyerly for the rest of this talk, but it's just, I wanted to just put those out so it's clear why that's there. Okay. Now, something that is critical for the health of individuals and of populations is that governments are not only responsible, not only for not directly violating rights, but also for ensuring the conditions that enable people to realize their rights as fully as possible. And what's key about this is that it points, in fact, to the fact that government obligations in relationship to health don't attach just to the right to health, but actually to a whole range of rights that are relevant to health. And, you know, it's not only the lecture series here, often, everywhere, the building in which I work, the right to health is the right that is always cited. But in fact, health requires attention to a whole range of rights. That right alone, even if by some miracle you were able to fulfill that right completely, you still wouldn't be able to fully deal with health in terms of all of the things that are necessary. Just let me give you one example. Think about those things that have been understood to be central to improving women's reproductive health. The kind of list is contraception, counseling, access to quality health services, education, and information. Now, implicit in this list is that even if actually these services are available, an individual woman has to have the ability to access these services. She has to have the ability to make decisions about her life sufficiently to be able to go forward and get these services. But think about how many young women have become pregnant unwillingly because they were denied access to services with the stated rationale that providing them with these services would lead them to be becoming sexually active. Now, recognizing human rights obligations in the ways in which all of these factors play out in terms of a young woman's vulnerability to ill health means that from a policy perspective and a program perspective that there's a cluster of rights that become relevant, and each one of them points towards a range of interventions both inside the health sector but also outside the health sector. I mean, in terms of the rights to health and the right to information, which I just mentioned, but take a look at that list. I mean, you need non-discrimination, the right to education, bodily integrity, personal security, privacy, equal rights in marriage and divorce. Each of these can be seen as relevant to an individual woman's ability to make and as well as to be able to effectuate the decisions she needs for her reproductive health. And each of these rights, therefore, becomes part of a government's responsibility for ensuring reproductive health. And the reason I'm emphasizing this is that what this actually says is that a concern with health that actually pays attention, and in a real sort of way, to human rights means that the studies that are done or the interventions that are carried out should, and I mean this based on a government's legal obligation, explicitly consider the civil, the political, the economic, social, and cultural context that surrounds it. And at a structural level, that means going beyond dealing with interventions only on their own terms, but actually consciously and explicitly taking into account factors like gender relations, like homophobia, like racism, like sexuality, that all of which can influence the extent to which individuals and communities are protected from discrimination, from inequality, and from exclusion, but also their ability to access services. And all of this should be, in many ways, from a rights perspective, taken into account in terms of how public health activities have been carried out. Now, having laid this all out, I want to talk about how actually consciously considering stigma, discrimination, and human rights can provide frameworks and instruments for thinking about how it is that we do public health work. And I just want to back up for a second and just start by laying out a key historical fact, which is that the first time that discrimination or human rights were explicitly named in any public health strategy was in the late 1980s when Jonathan Mann was the director of the Global Program on AIDS at the World Health Organization. Now, the first WHO global response to HIV called for the human rights of people living with HIV and AIDS and for compassion and for solidarity with them. Now, this partly happened as a result of the moral outrage that we were all feeling about what was happening to people who were living with HIV in countries all over the world. But in truth, a lot of the impetus for that to happen didn't actually come from there at all. It came out of the recognition that protecting the rights of people living with HIV was necessary for public health. Now, the fact that people living with HIV were being denied access to care, were being denied access to social services, to housing, to employment, to education, to a whole range of rights, was offensive. It was offensive to their dignity, but it was also increasingly being recognized to be counterproductive to public health. It was being recognized as being counterproductive to economic development and really to the structures and institutions that societies needed in order to function. The simple fact was whether the public health community cared about human rights in one way or another at all, the evidence was showing that discrimination against people living with HIV was driving people underground, and it was creating fertile ground for people not to know their status, not to be tested, and the way it was being said, to further spread the virus. Now, the point about this is that even though the public health motivation for doing this was not because of human rights per se, the implications of this approach being set forth by WHO, by the World Health Organization, as an intergovernmental organization were incredibly far-reaching. WHO, as an intergovernmental organization, in framing this public health strategy in human rights language, grounded in international law, and it therefore made governments and intergovernmental organizations publicly accountable for their actions towards people who were living with HIV and AIDS. And this helped draw attention not only to the responsibility of governments and of international organizations in public health terms, but in human rights terms, in terms of what it meant to reduce the impact of HIV and AIDS. And it brought attention to their accountability for what they did or they didn't do. Now, to be honest, from my perspective, the groundbreaking contribution of this isn't only about how it brought the language of human rights into the world of HIV and AIDS, but about the attention this then generated ultimately to the accountability of governments and of the UN system in general for issues relating to health and well-being more generally. Really moved the discourse and really moved the framework so people really understood the legal context within which this connections exist. Okay. So now I just want to say that from my perspective, the moral arguments and the legal arguments for why it is that governments should pay attention to the human rights dimensions of health and the ways in which they do their policies and programming are, I think, valid justifications on their own terms for why it is that they need to be paying attention to these in the context of health. But frankly, going beyond the moral and the intrinsic values of rights, rights-based approaches have practical value as well. And in fact, attention to these issues can actually make programming more effective. And it can help because it identifies and because it addresses the gaps that exist in policies and programs, and most importantly, because it focuses on how to involve affected communities in the policies and programs that exist. So what I want to do is to now make 5 suggestions as to how it is in a practical way that we can think about integrating rights into the ways in which we talk about doing public health work. And I want to just start off by saying that obviously this isn't about throwing out everything else we know that can work. It's about how concretely integrating rights into what's there can actually make things more effective. Okay, so first of all, a critical step is to analyze the broader legal and policy context within which a health intervention is to take place, and to determine the laws and policies that exist around an intervention that can impact on whether it's going to be successful or not in terms of how it's carried out. Just a couple of examples. A Ministry of Health or a group of health professionals want to put into place an HIV prevention intervention, which is going to include voluntary counseling and testing for sex workers, right? But there's a general law in place that criminalizes sex work. Or worse, there's a law in place that says that known sex workers need to be turned over to the police, right? So you can see how this general law can have an impact, even if the intervention on its own terms is just fine. The fact is, unless you're paying attention to the broader legal and policy context, you might not even know why it is that the service you're offering was going to be not going to be effective in terms of how it was there. Another example are in a number of countries where you have policies in place that deny married women the right to be able to access medical services without their consent of their spouse, right? So again, on its own terms, the intervention might just be fine, but unless you bring that into play as you're thinking about how it is that you design your policy and your program, you might well have a problem, okay? So that's step 1. Now, the next step is how human rights can be relevant to the actual analysis of the situation, of the actual policy or program it is that you may want to be able to put in place. And using the human rights terms that I was mentioning earlier, the availability, the acceptability, the accessibility, and the quality of the service that you're providing, as well as the outcomes among different population groups. Just as an example here, think about access to antiretroviral drugs for people living with HIV. And even within a country or a community where HIV treatment starts to become available, it's about determining who has sustained access to those drugs. And to be a bit more specific, it's about recognizing and actually trying to address the impact that gender norms can actually have on who accesses treatment, even if it's available, and who doesn't. Outside the focus of mother-to-child transmission, and the increasing attention to ensure that these drugs are not only going to be given to women to protect the health of the infant, but actually for the woman herself, we have to give much more attention than we have in the past to the place of gender roles and other factors of discrimination in terms of HIV treatment and care for women outside the context of pregnancy and childbirth. And even for women who are accessed for the first time in the context of pregnancy and childbirth, what's it going to take for them to access treatment in a sustained way over time? Now, 3 is how human rights can be relevant to the process of determining or shaping an intervention, actually the program that an institution might want to put into place. And here what I need to do is I need to draw attention to the fact that in any discussion of human rights in relationship to health, which is that the human rights framework recognizes that it can in fact be legitimate to restrict rights if necessary for the sake of public health. Now, obviously there are horrible abuses, and there are certainly many, many instances where there's been no need for the infringement on rights, and to do so has been highly problematic. Okay? But at times, public health measures may be needed to curb the spread of disease, and it may well be that to do so is not going contrary to human rights at all. Human rights do not in and of themselves conflict with restrictions on rights, so long as the restrictions on rights are clear. Now, lately, some people have been asserting, and again, we can talk about this in the discussion if people want, that human rights and public health provide very different approaches to responding to the HIV and AIDS epidemics. And the contention is that a human rights approach mandates that individual privacy rights be protected at all costs, despite their negative effects on the public's health. But this is entirely incorrect, because privacy is a right, in fact, that can be restricted if necessary for public health. But, and this is the key point, for such a restriction to be considered legitimate, a government has to address all of these criteria. And it's not just one of them or some of them, it's all of them, okay? It's all of them together. The burden of proof falls on those who want to restrict rights. And it's particularly in responding to these last 3 criteria that you need concrete evidence to be able to show that there's no stigma or discrimination in how the restriction is being carried out, and that it's actually necessary in order for this to be effective. And basically, the idea is about recognizing about a health and human rights approach is that you need transparency about how this decision was being made. You need to know that there was evidence upon which the decision was being based, and that it was validly discussed and debated amongst people who were able to think through what this was about. This is necessary to protect against abusive and counterproductive strategies, and to ensure, in fact, that even in the rising rates of HIV infection in vulnerable populations, that in fact people are paying attention to the processes that are being put into place, not just the result of what's there. Okay. 4th is about how the implementation how the intervention is implemented, actually where it focuses, actually what it is that it tries to do. And a key issue that I want to flag here is the relationship between governments and donors, with non-governmental organizations, with health professionals, and the range of different institutions that are necessary to make any intervention happen. And the first issue is really to think about the large power imbalances that exist between all of these different actors. And there has to be, and I think it was quite difficult, a willingness to openly acknowledge the power imbalances that exist, for example, in who has more access to technical resources as well as financial resources, and how that impacts on the ways in which they're able to communicate. And related to this, something that I think in terms of determining priorities and setting interventions that's actually quite difficult is a willingness on the part of all people, which I think is difficult for everybody, is to question the primacy of your own discipline, your own sector, your own kind of approach for decision making, and to recognize that other sectors and other approaches may well have something more to offer. And in fact, the way in which that communication can take place is really kind of the key for thinking about what a rights-based partnership can actually mean. Now, this focus on implementation also brings attention to non-discrimination, to equality, and to participation. And it really raises questions, not only in terms of who's getting what services and in what ways, but who's being left out and in what ways. How are decisions being made about the types of studies and the types of interventions that are being conducted, or the ones that are being funded, but also the ones that are not? Who's making these decisions, and according to what criteria? And where are effective communities in terms of these processes? Have they been able to meaningfully participate in these decisions that are going to impact on their lives? Now, bringing health and human rights together can also provide a framework within which the success or failure of a policy or program can be evaluated against not only public health benchmarks or human rights benchmarks, but through a combination of the two. I'll just give one example here. As I think most everyone agrees, information in terms of how something is working needs to be disaggregated. The idea is you need to be able to see who are the populations being impacted. Now, the question is disaggregated according to what criteria? So, for example, if you're going to disaggregate health data, should you disaggregate it on the basis of gender? Should you disaggregate it on the basis of race, ethnicity? Should you disaggregate it on some mix of the two? How do you make this decision? On what criteria? If you were to think about discrimination as a factor, and you would think about how discrimination would be a way that you'd want to be able to use as a method to be able to think about how you would determine who you would look at, does that mean, if you think about the Covenant on Economic, Social, and Cultural Rights, would you disaggregate health data on the basis of not only sex, race, ethnicity, but also language, religion, political or other opinion, national or social origin, property, birth, physical or mental disability, health status, sexual orientation, and other status? Now, the issue becomes here, how do we get at these differences? But who makes these decisions? And according to what criteria? How do we determine whether they're the most effective, and what are they going to be the most respectful in both rights terms as well as health terms? We can't do all of it, but we have to be thinking concretely about which are going to be the most effective. And also, how do we make sure that, in fact, the way in which information is disaggregated doesn't contribute to further discrimination of certain populations because of how that information is used or how it is that it's collected? Now, there's some creative efforts underway, but we need to be thinking much more about the kinds of criteria and the kinds of issues that these indicators would suggest. I'm going to close here and just say that my hope is that if we focus on this range of issues, that we can reduce the gaps between those who enjoy better health and better services and those who, for a range of civil, political, economic, social, and cultural reasons, are actually more vulnerable to ill health and to inadequate services and structures. And hopefully that this can support more informed targeting of health and social activities in the future. And I have to say that too often in the health sector, people that are concerned with trying to operationalize rights have been marginalized. And champions of these issues have found themselves actually in conflict for competing for funding, for a range of different things. And we need to think about how to mutually reinforce our efforts, particularly right now in this kind of global climate. It's extremely important that people come together and try to build on each other's work. And we need to better document the kind of work that's taking place. Now, in reality, we may never be able to demonstrate what's being asked for, which is the added value of paying attention to human rights, which means that in pure economic terms, that by paying attention to rights, things are definitely going to be better because we've paid attention to rights. Now, in some ways, it depends on how you do the calculations. But we can clarify the value of paying attention to these concepts and these approaches, and we can actually build the evidence base of the value of linking health and human rights. And that's why the fact this is happening here today is really important, and that's why I think that any kind of dialogue we can have about how this is being done, but also the ideas that you have about how you would like to see this being done could really be helpful. And with that, I'll just say thanks a lot.
We're open to questions now, but we are filming this, so if you raise your hand, I'll bring you a mic, and you can ask your question into the mic. Comments? Questions?
I really like what you're saying about having a debate and having a transparency for when certain rights might have to be restricted. And I guess the thing that comes up to my mind is issues of national security or of things like wartime, where human rights, or maybe not human rights, but rights in general, are much easily overlooked. I guess if I could say that right. And I was just wondering where you think that fits into your argument for that.
Sure, a great question. First of all, I think it absolutely fits in. I mean, I have to say, no insult here, but I have to say the current U.S. administration doesn't seem to be paying a lot of attention to that. But I do have to say that conceptually, in terms of how the human rights framework is set up, that's exactly what it's set up to be able to look to. And for example, when we talk about restrictions on rights, public health is one valid justification, but so is national security, so is public order. I mean, there's a range of different frameworks for which this has been set up as an approach. I will say, however, that while the first 2 points, in terms of in accordance with the law and the legitimate objective, are easy, the last 3, where I was saying you need to call on evidence to be able to do it, for the issues that you raise, it's not so clear-cut. And in fact, that governments need to be in a position where they can make emergency decisions at times where they don't have all the information. The questions become, what genuinely is a public emergency? And what is the criteria that's used in order to make that determination? And is there transparency on the part of the government in terms of how that decision-making was done? And that's where I think the issues kind of come in. But I want to be clear, it's not like, oh, this is so easy to do. Okay?
Thanks. I should say that I'm also a health and human rights person, very supportive of the project, but I just want to probe a little more the question of the tensions between health and human rights in just the context we've identified just now. Just to say that when we ask the question, what's strictly necessary, some problems arise. If an administration, for example, in the face of, say, a pandemic avian flu, doesn't put in place enough measures to prepare in advance, then certain more coercive human rights measures may appear to be justifiable because they are strictly necessary at the time, not having put in place measures to anticipate them. Do you have any thoughts on that?
Yeah, I mean, I think it's kind of the point I was trying to make before, which is the fact that at times it's easy to say that this should be done. I'll give you examples from the past, which was the Ebola virus. which was at a time when their information was not there. And in fact, governments took incredibly restrictive measures, which were more problematic than they needed to be. And you raise avian flu now, but it's untreated typhoid, untreated tuberculosis are a range of places where it's not so clear-cut as to exactly how it can be done. That being said, I think that for myself, the issue becomes really if it's discriminatory in many ways in terms of how it's applied. And I think that from my perspective, now speaking more as an advocate and not as somebody who's in a government's perspective trying to actually operationalize the criteria, I think that where you can look is you can point to where violations appear to be occurring. And in some ways it's an indication and it's a marker. And what you need, I mean, in the avian flu, let me just take avian flu for a moment as an example. What I think is interesting is right now how different governments are reacting. And the fact that some governments are entirely transparent in their decision making and others are entirely shut down about how they're making these decisions. And many questions I think come up as to that's why you need transparency in decision making, because it makes it much harder not just to say, oh, bad government, you're doing the wrong thing, but because what it allows you to do is it allows you to be able to see the decision making process, because I think everybody as reasonable people recognize that decisions can go wrong. But the fact is you've got to do the best you can. I also believe, I have to say, I also believe that most governments don't set out to violate rights. Governments think they're doing the right thing. The question is whether we can look back and take an objective set of criteria to make the determination that, in fact, this is, in fact, the right thing, ultimately, in both the process of how it was done and actually its ultimate outcome.
Can I just ask one quick follow-up? Might there be then discrepancies because certain governments will say, well, look, we don't have the resources you, America, have in order to address and prepare for it, and therefore we're going to do things which you would consider unnecessarily coercive, but we have no choice?
You'd have to talk to me about the government, because I actually think some of the most coercive governments are some of the richest. And so I actually think that that's an easy fallback. And so, in fact, it comes back to the question about where are economic resources the key to being able to make decisions, or is public health evidence, in this case, going to be the most effective? Because, frankly, the most coercive may not be the best in public health terms. Take HIV and what happened at the beginning of the epidemics in a range of countries where, in fact, the most coercive measures actually drove people underground. So it's not clear that most coercive is going to be the most effective.
Can you do what you had promised earlier and go over the treaties that the United States has ratified and talk about how we're doing with them?
Okay, sure. All right. Okay. So the Universal Declaration is not a treaty. So not an issue here. The U.S. was part of the decision-making process. It's a declaration. It's not a treaty. The U.S. in the U.S. there is a two-step process to being ratifying a treaty. There needs to be the president of the country needs to put forward a treaty, needs to sign the treaty and say to the Senate, I want this treaty to be ratified. Then you need the advice and consent of 2/3 of the Senate. So it's a two-step process, okay, which is what's key here. All right. Now, the treaties that have been ratified are the Convention on the Elimination of All Forms of Racial Discrimination, the Covenant on Civil and Political Rights, the Convention Against Torture. Okay? The treaties that have been signed indicating, and I want to be clear, the ratification took place when the first George Bush was in power. So this is not a Democratic-Republican issue. That in fact ratification took place of race, of civil and political, and of torture during the first George Bush's administration. Now, the other treaties, with the exception, I'm going to talk about the Convention on the Rights of the Child and migrant workers separately. All of these treaties were initially signed by President Carter. And every one of these treaties came up to the Senate Foreign Relations Committee every year for discussion. And every year were turned away, except for the few that I said that have been ratified. Now, in my lifetime, I do not think we will see ratification of the Economic, Social, and Cultural Rights Covenant, nor the Convention on the Elimination of All Forms of Discrimination Against Women, nor the Convention on the Rights of the Child. President Clinton had taken the Women's Convention as his personal kind of hobby horse that he was riding, and he was really anxious to get it ratified. It didn't happen for a range of political reasons that aren't worth getting into, but I can get into it if you want. But because of that, that one has fallen off the table. The Convention on the Rights of the Child was only put into place, and only was, the first step of that was only done actually when Clinton was president. And it was really because the head of UNICEF, his deathbed wish, James Grant, his deathbed wish, was that the U.S. sign. So it was done because it's the first step of the process. It was signed but not ratified. So he did it literally at his deathbed and signed it, but that didn't move it to the next step. And I will say that the Convention on the Rights of the Child, let me just back up and say, the Covenant on Economic, Social, and Cultural Rights is one that the U.S. government has never, ever liked, because many of the things in there, like the right to health, are considered to be entitlements and not rights. And so they are things that have economic resources attached according to the way that U.S. view of civil and political rights being the ways in which we understand human rights to be. And therefore, the Covenant on Economic, Social, and Cultural Rights is not something that will happen anytime soon. The Convention on the Rights of the Child, we are the only country in the world, except for the collapsed state of Somalia, that has not ratified that treaty. And the reason for that, besides the politics, is that it is the only convention because of when it was drafted was after the end of the Cold War. So what it does is it blends civil and political and economic and social in one right. So it's much harder to disentangle and to decide what the U.S. wants to be bound by or not. And just as an example, the right to life has the right not to have your life arbitrarily taken from you, which is understood to be more of a civil and political right, but also it also includes the right to survival and development, which is considered to be a more of an economic and social right because it has economic resources attached to it. And so that one, we remain the only country in the world, and Somalia looks like they're getting their act together, so we may soon be the only ones in the world who have not ratified that treaty.
Kind of going off, sorry, too loud. Kind of going off of this, what kind of structure and infrastructure in terms, I know you talked about the groups that monitor these treaties, but what kind of penalties for not following through on the ratification? And for further also with that would be, is that to a larger extent the reason for us not signing possibly these treaties is our desire not to be involved within structures that would restrict our government or what we feel will restrict our government rather than the human rights issues that come up from it.
Okay. If I don't answer your question, hold onto the microphone because I want to respond to those points, but I feel like there's a couple of points in there. The first issue has to do with who are the groups that monitor and how do they operate. And there's a couple of things to say. The treaty monitoring bodies are official bodies of the UN system. And those people are there as independent representatives, but they're only elected from the governments that have already ratified the treaty. And so they come together as an international decision-making body, for lack of a better term. So they're not considered that independent. I mean, they're independent in that sense, but they're not the NGOs, which are also doing reporting, or the media, which are also doing reporting. So it's really in terms of that sort of body and how they operate. And frankly, you need to look at each one of those actors individually. One of the things that I think is interesting is that when those concluding comments come out, when governments report, and when those concluding comments come out, in most countries of the world, the media reports on how the country's doing because people have interest to know how their country's doing. In the US, it's not reported. And there's no conspiracy. I don't think there's a conspiracy. Just why isn't that of interest? I mean, I find interesting. And so, it seems to me that you'd want to know how the US is doing. When the US has been up in front of treaty bodies, it's other countries that have reported on how the US is doing. Which comes down to your second point, which is, does the U.S. not want to participate because it doesn't want to be held accountable in this kind of form? But it does it on these other treaties. So in terms of civil and political, in terms of race, and in terms of torture, it appears every couple of years, and it comes forward. And it says when it comes forward, it provides a report. There's shadow reports. The whole process goes on. Again, you can download all of it just to see what happens. And most recently was when the U.S. was up in terms of the racial discrimination covenant. And the thing is that we have really good laws in this country. The issues that we have tend more to be about implementation and how they're implemented. And so the question becomes in the dialogue was, as opposed to a lot of other countries where the laws are bad as well. So what comes forward is the laws are really good. Now, the U.S. didn't do a really good job about reporting about problems in implementation. And so about 125 U.S.-based groups came together and jointly submitted a report that talked about police brutality, that talked about a range of things that were occurring in terms of how actually policies were being implemented. And that was then able to be used in dialogue. That got tremendous press all over the world. The U.S. didn't report on it. And it was just really, to me, very interesting that that's how it came up. And in terms of penalties, a couple things. This is a system that governments set up for themselves. You need to always remember that about human rights. They didn't want to set up a system that was going to really put themselves in a really bad situation, because governments said, this is the way we're willing to be held accountable. That being said, don't underestimate the value of public shame. Governments don't like to be embarrassed any more than people don't like to be embarrassed, and the way that that's used is really important. Now, the question is it used by one government against another government, in which case it has a political tinge? Is it used by the media? Is it used by civil society groups? And how is that information used? And most important in many ways is getting that information out there so people know what's happening. Did that?
Yeah.
Okay.
I was wondering about the tension that you were describing between the government and different racial groups who have been labeled as having some sort of deficiency in like taking care of themselves. You see these. You mentioned it earlier, and I'm sort of rewording what you were saying, but I'm just basically curious about how the rhetoric or the policy on international or on a national level would go about affecting self-injustice in a way, like, and I'm recognizing that there's a tension because a lot of racial groups and ethnic groups have been labeled as not able to take care of themselves or something like that. But I think it's quite non-racial in its spread. I think that everybody is a problem with just lifestyle decisions that affect their health and thus weigh upon society in a way, because everybody has to take care of these people who aren't taking care of themselves. I'm just wondering how this is a lot about government individual interactions, but sometimes the individual is the source of the problem as well.
Well, let me see if I'm responding to what you're saying, which is that I think there's a couple of things here. One is this doctrine of individual responsibility that seems to be really taking people out of the context in which they live and focusing on individuals like we're automatons that don't exist without a structure around us. And I think one of the things that happens often is that by pulling individuals outside of the larger context in which we live, it's very easy to make judgments about lifestyle and about behavior. And one of the things that happens is that I think that gets used and that polarizes the ways in which groups talk about one another and the ways in which individuals talk and understand one another. And I think I believe the role of government is to be able to look at evidence, to be able to actually make decisions effectively, and to move beyond that rhetoric. And so one of the things that I think is really problematic is when the notion of this kind of individual sense of individual without a sense of individual connected to other, the legal and policy context in which we live, the communities in which we live, the households in which we live, I mean, the range of the schools in which we go to, I mean, the whole range of other things that are connected to us that impact in terms of how it is that we're structured. When we're separated out, I think that that's when public policy decisions ultimately become more problematic. And I think that one of the things that I was pointing to at the very beginning is that often what happens as a result is it allows governments not to provide resources towards communities that are particularly disadvantaged. And I think that's, from my perspective, that's where there's a real problem, because it focuses, I think it misfocuses and it misguides actually what's actually going on.
Yeah, I just have a quick question. Earlier you said the U.S. views health as an entitlement and not as a right, and that's why we're not signing the Covenant on Economic and Social and Cultural Rights. I'm kind of confused on how they make the distinction between an entitlement and a right.
I'm a bit confused too, but I'll try, okay? So the idea being that there was an initial understanding, well, let me back up, in this country, okay? And in other contexts, the ways in which rights have been understood in their historical base are quite different. But in the context of this country, the sense of rights was the sense that the majority of rights were negative rights, meaning those things that the government cannot do to you, and those things, therefore, if you think about it, those things that don't cost money. Okay, because it's about your freedom in terms of how it is that you can operate. Within that, there was the understanding that there were also things that were considered rights, like the right to vote, right, which were considered to be things that you just have. Now, what became clearer, now moving outside the U.S., but I swear I'm answering your questions, like just to move outside the U.S., was the idea that, well, actually the right to vote takes money. You need to print ballots. You need to train people as to what it means to vote. You need to put up polling places. You need to put up candidates. I mean, there's a range of things that need to be into place if you don't have a system that's already exists. And there's a recognition that even those civil and political rights that seem so simple are actually much more complicated. In this country, because we had a historical tradition where we've been sitting in civil and political rights for a long time, we haven't had to worry so much about the economic implications of many of those rights. And so it's been much easier to distinguish in terms of being able to say, well, these rights we buy and because they don't actually cost us anything, whereas these rights are costing. I mean, take education, which is the other one like health, which is one where there's an understanding that, in fact, we don't see that as a right. We see that as something to which you can be given, you are granted, and only under certain conditions, right? And so that's where the distinction is made. And again, I mean, it's because of how I'm presenting it. If you had somebody here who was a representative of that point of view, they would likely represent it as being able to say, these are quite distinct, right? This is a right that really has resources attached. This is a right that really does not have resources attached. Therefore, this is not a right. And so, what I think is difficult, and I think for me, most of my work is not in the U.S. Most of my work is outside the U.S. And I think that as a result, for me, it's changed my framework of how I think about these things now, because I really do see that there are other disciplines, other traditions that take it very differently. So.
Yeah, that does. But so my next question is just kind of, do other countries we're one of the only countries that don't have socialized health. So do other countries then view health as like a right then? They do attach that association with it, just not us?
I don't want to say just not us, but I don't want to make us quite that much of an outlier. There are other countries that feel similarly. But I will say that at this point, there are 164 countries that have ratified the Covenant on Economic, Social, and Cultural Rights. And certainly, as I was talking about, the Convention on the Rights of the Child has specific rights in there that are very specific to the right to health. There's actually a specific article that's absolutely about the right to health. And the same is true in terms of the other treaties. So when the U.S. has separated itself out, it's tried to, in those treaties that have health in them, it's tried to limit its obligation. And let me just give you one example. You're allowed as a government, when you ratify a treaty, to take what's called a reservation declaration or understanding, meaning you can say, I agree to be bound by this treaty except for this provision, which I don't want to be bound by. And so the U.S. is bound under the Convention on the Elimination of All Forms of Racial Discrimination. Okay. In that treaty, one of the articles, Article 5, has a specific provision that's about health, and it's about equality of treatment based upon race, in terms of not access, but once you're in the service. So what the U.S. did is it took a reservation saying, look, we're not really into the access part, but we believe in the equality part. Okay? Because they were able to distinguish that in terms of what our own traditions are. Okay?
Okay.
I got another one. Kind of going somewhat in the same area as he was talking about. I kind of listing some of the rights that you've listed, and you mentioned like some people consider like the right to like HIV care as a possible right. To what extent would you think that maybe are we getting a little too concerned about getting too fine-grained with some rights that we're developing, and maybe we're saying, oh, by saying that HIV is so specific, like, well, what makes HIV different from other diseases, and why is that a right and not another disease a right? And to what extent is that maybe adversely affecting how we're developing good human rights?
No, I think it's a great question. And I think that I have a lot to say about that, actually, because I think that it's easier to spend time advocating for adding rights than working to implement the rights that exist. And I find that there's almost like a whole business of people who are working to push for human rights treaties, to have new treaties on new topics, okay? At the same time, take the U.S. Constitution. It's a living document because it's a document where the rights are there, and it's about the interpretation and what's done to make it more active and to bring it alive in terms of as things are needed. And the question becomes, do we need more rights, or do we need more understanding of how to implement them and to make them more valuable for everybody? Now, I fully see the problems that we have is that if we don't spend energy trying to push for rights, you lose public attention to those things. I'll give you examples kind of from the recent past, is that it was that, for example, the women were not really being considered in terms of how these treaty rights were being understood. So even though torture was understood to be a really bad thing, rape was not included in the definition of torture. And so the fact that rape was occurring was a bad thing, but really not torture. And if it hadn't been for advocacy groups pushing and making it clear that, in fact, that definition needed to be expanded to include rape, rape would not have been included. And so it was really important to push, and I feel that way about HIV treatment. It's really important to push, but my own perspective, but I realize I'm me as I say this is okay, is that I think we need to be pushing for understanding within existing rights rather than necessarily pushing for new rights and new rights and new rights. But I also see that there's a tension there. Okay?
Since we've run out of time, please join me in thanking Professor Gruskin for a wonderful conversation.